Started in a moment. Thank you all for joining. Please feel free to use the chat. I'll be monitoring that as we go. And do let me know if there's anything that you'd like covered. We'll be talking about a broad range of TriNetX related resources today, in addition to starting and developing a project. This is similar to the process that we use in our own course at UCR School of Medicine in the Health System Science Project course. So this mirrors some of those activities, but in a much more condensed form and a much more practical form for those who are residents or attendings who want to support students on projects, or if you are a student who wants to get a project lifted off on your own and you don't know where to start. Thank you so much for joining us tonight. This is the first of a series of 6 sessions in the bootcamp. I am your instructor, whatever you want to call it, facilitator. My name is Daniel Novak. I'm Director of Student Scholarly Activities here at the School of Medicine. I am an active scholar. Here's some stuff I've done in the past. I worked in a broad range of methodologies, including highly quantitative research, as well as highly qualitative research, as well as my own expertise in the area of design-based research, which is unique to the area of learning sciences that I come out of in my own doctoral work. And in the last couple of years, I've been really developing and working hard to learn as much as I can about clinical informatics, especially as results from or as facilitates the development of student research, high quality student research with TriNetX. I want to be clear that I do not get any funding. Nobody here gets any money from TriNetX. TriNetX contract with UCR is a $0 contract, meaning they don't pay us, we don't pay them. The only thing that gets changed hands between us and TriNetX are opportunities for involvement in clinical research, which is what they send to us, and the data that we send to them. Otherwise, there's no funding or conflicts of interest related to that. I don't have any relationship with them beyond our UCR contract. I really, other than contacting them for help and discussions about future resources, don't get anything from them. Some of my salary time for this bootcamp was paid for with funds from an NIH U54 grant held by UCR and City of Hope, but I'm not getting paid anything extra as a result of that, so there's no additional conflicts of interest related to that. So I just want to make that clear at the outset of the bootcamp that we do this because we want to facilitate student research, and we think TriNetX is a great platform for that. However, we also believe that what you learn from this process, from learning about TriNetX, using TriNetX, goes beyond just this one particular data set and platform, that it is an opportunity for you to practice core foundational research skills and perspectives that will facilitate your growth long-term and allow you to do other more complex, involved kinds of observational research in the future, but also to set you up for success when you do get your own NIH grant, your R1 in the future, and get some money from those to conduct more complex clinical trials. But this is foundational stuff that I think is going to be really valuable. In that spirit, our bootcamp goes through 6 phases. Our first topic tonight is just navigating TriNetX, understanding the interface, and developing a project. I think it's very user-friendly and simple. However, there are some things, there's a bit of a learning curve, and I think by having somebody walk you through it will get you right over that initial hump and into using the platform more effectively. So in week 2, we're going to talk about defining and exploring cohorts. That's kind of like hump number 2. Hump number 3 is comparing cohorts and propensity score matching. There's some really great statistical concepts in there that we're going to explore as we talk about what is a cohort comparison, how we do them effectively, and also what is propensity score matching and how does it work and what are its limitations and what are its real strengths as a statistical methodology. We're also going to, in week 4, talk about conducting outcomes analyses and getting ready for peer review, self-peer review. In fact, we're going to use, I'm going to show you guys a new tool I've developed to help facilitate strobe peer self-reviews and self-evaluations to make sure you're in line with what journals and editors are looking for in terms of quality of stuff before you even submit it. Week 5, we're going to add, this is new for this year, Cox proportional hazards models and treatment pathways. They added the Cox proportional hazard model 1 month after I completed last year's bootcamp, and it does a really cool job of allowing you to look at how different kinds of factors can impact an outcome for a population. So that is, I think, something really powerful and useful. And the treatment pathways tool is also very cool for that similar reason. Posters, manuscripts, and writing tools are going to be in week 4 and week 6. That's kind of a more practical thing for how you can get from your current position to the next, from completing the analysis to actually making something that you can submit to a conference or a poster that's of a high quality. We are shooting for very high quality observational research, and I believe that we have developed some really strong tools to help make that possible. Overall, Bootcamp's objectives for the summer is that you'll learn to navigate the TriNetX interface, what to click, right? But also as important, conceptually, to identify worthwhile projects, compare outcomes between patient cohorts, how do we do that? And to use propensity score matching to reduce confounders. This year, we also have some additional ideas related to using AI to help with your process, both in terms of developing your project from the beginning and developing more advanced analyses later on, helping to spot confounders and to use the really powerful tools that are evolving in the AI space to augment your own knowledge. Even very experienced clinicians may need to consult AI to identify some things that might be confounders that have been identified in the last few years. And I think that's really something we want to explore and promote, using AI in a positive way. Today's session, we're going to talk about a big picture overview of TriNetX. We're going to look at navigating the interface, the key features, and we're going to think about the front end and the back end of how this process works. We're going to talk about developing a project and identifying existing studies and finding what I call a TriNetX recipe. And that's kind of an extended metaphor that I include as part of our discussion today. I do want to note, though, that this is not purely technical training. I do have students who ask me in our student evals and stuff like that, can you just tell me what buttons to click? How do we use TriNetX? I'm like, no. TriNetX is merely a vessel for understanding core research competency ideas. Things like, what are cohorts? How do they function? How do we relate them? How are medical events or health events related in space and time? How are they related? How is causality determined, right? These are all big questions that I say I'm hashtag not that kind of doctor. I'm a PhD, not an MD. So these are big questions of meaning that really kind of are interesting to me. And this is a tool, a platform that we use to explore that. Each session is going to cover a major piece of the technical training, but also provide you with conceptual guides on how to think about the data, the platform, and the project. So we're not just mindlessly clicking buttons and looking for P is greater or is less than 0.05. We are thinking about what we're doing. We're using this as a way of understanding. And that is something I think is really powerful. Please do not skip either part. If you're watching this in the past, or if you're planning on jumping in later in the future, you need both a conceptual and technical understanding to make the most of this platform and to produce high quality projects that are going to be valuable to people in the long term. We have a number of resources available. I've put the link in the chat, and I will link again to make sure that you get a link to that. We have books and articles. We have websites and tools all available. Good recipes for TriNetX. My apologies. I just want to spend 1 second inviting somebody is lost and needs to be oriented. My apologies. Just going to forward. If you know anybody who is having trouble accessing our event tonight, please let me know. I'm just inviting this in. Okay, great. So we got resources, and let me just quickly show you. We have our scholarly activities portal. We have a number of really valuable resources in here. In addition to, if you haven't requested, as I mentioned earlier, if you're a first year incoming medical student and you need to request your TriNetX account, you can submit this through here. Please, everybody, just make sure to use your @medschool.ucr.edu account as specified in the request over here. We can't issue one without that, so please do that. We can make exceptions if people are at other colleges, like if you're in Borden College or something like that. We can talk about getting you one with your @ucr.edu, but we really do need people to be joining with their @medschool.ucr.edu if at all possible. This is our website again. I also want to call attention to and put a link to in the chat that we have a TriNetX project bulletin board with a number of really great project ideas submitted by faculty. There's a little button down here you can use to add additional projects if you want to try to recruit additional folks to your project. If you want to work on it together, you can add projects in here. We make this very easy for people to use, and some of our colleagues over at RUHS have done a great job of populating some real great ideas for projects to investigate for the projects that we have in our course. I also want to highlight our research, again, our research resources. We have books on clinical epidemiology, handbook of epidemiology stats. If you need help with stats, some of these books are free. They're all free, but they're all very good quality and can be very helpful in that. These are some additional resources for finding TriNetX studies here. We have TriNetX publication database, Google Scholar. I also teach our students about Research Rabbit, which is a tool for identifying networks of publications that can help to really find unusual studies or things you might have missed if you were merely using PubMed or Google Scholar. We also have a list of exemplar TriNetX studies. I tried to curate, projects in a number of different domains that might be useful for folks that are similar. We have things related to maternal outcomes, psychiatry, all sorts of different areas, GI. And so these are ones that I think were pretty good quality, all in all, that might be of value to you in the long term. So I'm going to put that link in the chat for those who are interested as well. We also have links to the TriNetX help videos. These are built into the platform, but if you're logged into TriNetX, you can click this button and it'll take you, it's a deep link into those videos that they have that can add additional information about different dimensions of the project, the platform, including best practices in querying patient diversity, which is a really important concept to think about, and some of the advanced analytics functions and even basic functionality. I also developed a TriNetX research planner in ChatGPT. I trained it on a number of TriNetX documentation tools, studies, documentation, CPT codes, ICD-10 codes, so that this would enable folks to help build their studies more quickly. I believe it's been used something like 2,000 times already in the last year. So it has a lot of ways to really benefit you. And it knows more about TriNetX than the vanilla ChatGPT that you might just encounter in the wild. So that's useful. And I also have some templates. We'll go over these later in session 6, some templates that and tools that I think will be very valuable. If you're a longtime TriNetX user and you're joining us today, at the end of our session, I'm going to premiere an additional set of 6 tools that I've put together for you guys to help make publication posters, to produce higher quality graphics, more reliable tables, so you don't have to worry about errors creeping in and things like that. I'll be talking about that more a little later. So I just wanted to make you aware of some of the resources that we have available starting this year. Also, if you are new to clinical research, I used my professional development money this year to buy as many good quality books on clinical research as I possibly could, to review one that I would find that would hopefully have the most useful stuff for you. So this is, I think, one of the best ones. It covers a lot of the limitations in observational epidemiological studies, but also talks about some of the strengths and some of the core concepts that you're going to use. So I really recommend checking out this book. I believe we have a digital copy in the library if you need it, but it's very, very well written and very concise. It's really, really short, but very well developed. Recordings, if you want to go back, you can. We'll be posting the recordings on the Scholarly Activities portal again this year, just like last year. You can see, if you want to go back and look at the 2024 ones to get a sense of what's coming up ahead. You can see all of the videos from last year right here on our website. We're going to have exactly the same page just for the 2025 version coming up, including, as I said earlier, we got some lecture notes. I basically feed the transcript into ChatGPT and try to develop a little overview of it. And I'm experimenting with some new educational technology platforms that might make this even more useful for folks by providing, summaries and quizzes and things like that using AI technologies that are available. So the videos have been viewed over 3,000 times since I put them up last year. And I've been getting emails from all over the world, including all over the US, St. Louis University, people at Detroit, at Wayne State, all over the country and all over the world have been asking me TriNetX questions. It is not something I can always keep up with, but it is good to know that this is being helpful to people. So I hope you'll find it helpful as well. Again, if you are accessing TriNetX today, I'm just going to put in the chat. You'll access it at https://live.trinetix.com. We also have a short bit.ly to it. I don't know if it's that much shorter than that, but if you want to go log in to your account, this is a good time to do that today. All right, so a lot of talking. Let's get into it. This is, we're going to launch on TriNetX, but first we got to talk about TriNetX. I know a lot of people struggle with it because it's a name that's too clever by half. Whoever came up with this tech name, it actually makes sense. It's like Trial Network X, but they say it TriNetX like genetics. That's how I have kind of learned to say it from them. But let's talk about health informatics. So what is TriNetX? For those of you who are new to this, what is it? Why? Where did it come from? Why should we care? Well, TriNetX is actually a clinical informatics platform that was developed to facilitate clinical trials at multiple sites. So let's imagine you're Pfizer and you're developing a new drug and you want to test it, but you need a very specific set of patient pools in order to test your drug properly. You're going to have your methodologists over at Pfizer. They're going to tell you you need 26 white men with lipid profiles like this, the age of this and this, who are not on this drug, and you need this and you don't need this. And we need 36 Black women who have this profile and they have never had children and never had cancer. How are you going to find these? In the old days, you used to have to call up all of the different sites that you knew had folks like this, or all the different trial centers, and you have to get them to sign on. And then you'd have to go through their individual process for contacting people and identifying patients. Well, the idea behind TriNetX was to create an honest broker system that allows you to look across all of the health networks connected to it and identify what health networks, number one, have the right pools of people, and number two, what health networks are most likely to be able to recruit and have a successful trial as quickly as possible. So this system has, over time, developed access to, I think it's today 71, it's not 80, it's 71 healthcare organizations across the US. That includes us, but also UCI, UCSD, USC, Johns Hopkins, Virginia Tech Carilion, University of Iowa, University of Alabama, the University of Texas Medical Branch, MD Anderson, all sorts of major healthcare organizations. And those are just the academic medical centers. There's also a range of other large health networks that do clinical trials connected to it, plus 12 more countries globally, including Japan, Israel, Russia, France, the UK. Health systems at Oxford are involved. So the data is being brought in directly from these electronic health records on a regular basis. And that includes only structured data, so no imaging and no patient notes, which is a limitation. However, you make that trade-off for comprehensive demographic, not comprehensive demographics exactly, but substantial demographics like age, sex, language, racial, ethnic category, marital status. You get diagnostics using the ICD-10 system. It has its own limitations, but also some strengths. You can search by procedure codes, both the CPT and the ICD-10 PCS codes. You can look for drugs by brand name, generics. You can look at dosages. You can look at multiple different systems for categorizing drugs. You can look at all sorts of treatment pathways related to drugs. You can look at labs. Anything that has a lab value, a LOINC value, that's collected by the health system and categorized in their LOINC system can be pulled. That includes A1C, blood pressure. You can look at values over time. You can look at values at an individual point in time. You can also look at PHQ surveys, like the PHQ-9 surveys are in there. Other kinds of survey data that systems collect routinely. Now, it requires, of course, that all of those data make their way into their electronic health records. If they don't, if they're collected in some other system, on paper, or stored in some file somewhere in the hospital system, then we wouldn't have access to it. So that's something to bear in mind as a limitation. But we also get some genomics from health systems that collect it. That includes cancer genomics from health systems that are routinely collecting advanced cancer informatics data, like MD Anderson and the Norris Comprehensive Cancer Center. And we also get visit type. Was this an ambulatory visit, an inpatient visit, a hospital stay? Was it a short stay, long stay, a virtual visit, an emergency visit? All sorts of information about that could be useful for a study. One thing that's nice for some of the trade-offs that we're going to talk about that make this less than ideal, like a bad choice in some cases for certain kinds of studies, there's no HIPAA information included anywhere in the platform, meaning that this is non-human subjects research. There's no time. You don't have to spend months going through the human subjects approvals process for this. And I'll talk later on in the later lecture about how we manage human subjects approvals through UCR. But one thing that's nice is you really can't do any damage. There's no real way to accidentally breach HIPAA rules. They've really put some strong guardrails in there that even some cases are a little constraining. For example, neonatal data codes that use the P series in ICD-10 are restricted so that you can't access them because TriNetX and their IRB affiliate and their independent IRB that looked at this believe that it's too risky to have pediatric or neonatal data available to folks for. You can see it, but you can't analyze it, and you can't look more than at the cohort level for it. And I guess that's hard for us because we want to run neonatal outcomes data, but we understand that that's part of the deal. One thing that's good is that the average age of patient records is roughly 7 years, so you get a nice longitudinal slice of people's health records. And some of these records are as long as 20 years, depending on how long the person has been going to their health system and how long the electronic health record has been in place at the health system. Data is refreshed weekly or monthly, depending on the organization, which I think is a really great feature because you can actually look at changes in real time. We had one group of students do an analysis of the impact of the Dobbs decision from the Supreme Court on patient decisions about abortion and both procedures and medication following that. And they were able to look at several years before and the intervening 2 or 3 years since to see whether rates of procedures and medication application or rates of abortion generally have changed in that time. And the answer is yes, they actually did dramatically change. But because these data are refreshed very frequently, we were able to mark that time and really see what's happened since then. All the data is time shifted, meaning it could be, they say the average time shift is between 3 days and 2 weeks. So if you ask for data about a particular day in order to protect patient information, they shift that date of service a couple of days because it is date of service is a HIPAA characteristic. So everybody is protected. However, it means you can't really get a real true temporal resolution below time frame. But because of the way Dobbs rolled out, that wasn't fatal for our study, and 2 weeks more or less didn't make a difference for our study. Let's talk about how the data is structured. We've got kind of a series of nested data sets. There's a global data set, which includes the US and all of the partner countries. It has about 166 million patient records in it. The US data network, with its 69 or 70 health networks, has about 120 million patients on any given day. The UC Collaborative Network of UCI, right now we're not updating UCSD's data as frequently, but it has about 1.3 million patients in it. We all know those are in Southern California, so that can be really valuable. However, by the way, this number goes up to about 2.6 million since UCSD data is available in the platform, but it's just not being updated. So it's updated through, I think, December of this past year. I believe they were not able to have the funding to continue sending their data to TriNetX. We also have the UCR health data included in here as well. This does require, we require going to UCR Health to talk about why we're using their data, why we want to access their data. So by by default, everybody here who gets a TriNetX account gets access to the global, the US, and the UC network, but you're going to have to ask for UCR help just because it is our health system and we want to keep it safe, keep those insights safe. Geography is obscured beyond the UCR health group, so we don't know where people are geographically. We're going to talk about that as a limitation in just a minute. But one of the benefits, I think, or one of the useful features of this is helping students understand cohort-based research. That is looking at cohorts and looking at how folks that share common characteristics, be they demographic or medical, how those can impact their outcomes over time, and that can be really useful. The studies are retrospective, but cohort comparisons can be used to create natural experiments using real-world data. That's one of the really interesting aspects of cohort-based research that I think is very compelling, is you can do stuff with cohort-based research and create kind of simulated experiments that you couldn't do in the real world. Either, we'll talk about it a little bit, either because it's unethical to deprive people of particular kinds of treatments. However, you can look at an aggregate where people decline treatment or are otherwise just not given a medication, right? That can be very insightful in terms of outcomes, right, for people later. One of the tools that really helps make this, I think, methodologically more rigorous, propensity score matching, we're going to talk about this pretty extensively later on, the statistical logic behind it, can help to adjust for confounding variables, especially in the very large cohorts that we sometimes see in this platform. There are limitations to propensity score matching as a methodology. There are it has a boundary in terms of its ability to adjust for bias. However, given that it is a very reliable methodology in other ways, I think it's a pretty good choice for this. One of the things that we're going to look at that I think is very useful in TriNetX is the cohort builder. It's very easy to use. It's possible to search for different kinds of healthcare conditions. If you're looking for, asthma, it's very easy. Just type in asthma and you'll see all the information about it. And I'll show you in just a couple minutes how to navigate some of that. But I think it's particularly user-friendly in that way, in terms of being able to search for things. And if you have trouble finding certain things, sometimes it's easy to just Google the code for it and put that into TriNetX, and it'll cross-reference it for you and find that in 2 seconds. One thing that's nice compared to other platforms out there, other data sets, all of us, Truveta, all the other ones that are available, you don't need any coding, no Python, no SQL, nothing. And that's a very deliberate decision on our part, because we know how busy medical students are. We know how busy attendings are, and we know how much of a bottleneck. We love our biostatisticians, but there are just a finite number of them that we can call on. So having a platform that can help you do that work so that you can get to a high quality, at least initial study before, say, running it on your local Epic installation, or can help you get to a high quality analysis this way within TriNetX, that's what we're looking for. That's what we really want. Again, it has powerful in-system data analysis tools. It will run the stats for you for your outcomes comparisons or your competing risks or your Cox proportional hazards model. You do not have to learn R to do this. You do not have to learn Python or SQL to do these analyses. You don't have to download packages or whatever. It's all done on the platform reliably. They've tested it on a number of different artificial data sets and have found out that it is these do a very good job, these packages, of being accurate and reliable. As I said, there's a series of tools. We're going to go through them a little more in a couple of weeks. Those including analyzing the cohort, looking at different features of a single cohort, looking at competing risks between 2 cohorts, looking at treatment pathways, how many people get, aspirin versus ibuprofen, or get ibuprofen versus an opioid. That's easy to see in this tool. It can look at incidence and prevalence. The Cox proportional hazards model is really useful. It has advanced cohort explorer features, but the most common one, and the one we're going to focus on mostly in this, is the compare outcomes. That is, comparing outcomes for 2 groups of people who have either share a common characteristic or do not share that common characteristic. Easiest way to kind of help you guys understand the other kinds of potential analysis is to look at that, because it requires us to go through all of the components of the platform to really do a good job. I will say it is, because this is a very common question, it is possible to get data from the TriNetX research network off of the platform for analysis. However, we're not currently supporting that for a couple of different reasons. One is it's not something you can just throw in Excel and look at. These data sets can be 15 or 20 gigs of data. They're going to require table joining, SQL or Python knowledge. It's not just for the weekend warrior to use these data. So we want to make sure that in the future, when we do support this, we have biostatisticians who can help with this. You're also going to need to go through a contracting process, and the IRB will need to review it. So those are some reasons we're not currently supporting data downloads for our students and our users right now. It may be disappointing, but I really want to see that you've maxed out the use of this platform before I'll support folks on pulling the data off the platform and setting up that system. As we move towards actually looking at the platform today as part of our conceptual work, we want to talk about bad use cases for TriNetX, things and questions that are not good for this platform. So I just want to be clear for folks that some of these are not, it's not a perfect system. There is no such thing as a perfect research study that answers all questions. It is, however, a valuable tool with these limitations. One is related to geography. There is no geographic data available for analysis in TriNetX. Partially that's to protect, even at the state level, it's not possible to do, let alone at the zip code level. And we know how important zip codes are, right? Your zip code can be more predictive of your health than your genetic code, they say. That's very true. However, this is to protect the healthcare groups and the people that are in this platform, because if you could get that close geographically, it might actually, you could predict, if even by state, sometimes like University of Iowa is the only healthcare partner for TriNetX in the University of Iowa. So if you were able to select that state, you would know exactly what health system everybody was from. And you could use that to further refine down till you were looking at individual outcomes and breaching our HIPAA requirements. So no geography. It's disappointing, but true. Questions related to insurance status. I'm told that they're working on it because those data are actually in the back end of the platform. Public, private, PPO, HMO, that kind of stuff. I guess mostly not HMO, but whatever the insurance model is that the person is on. And I'm asking them to, I've actually talked with the TriNetX people a couple of times to ask them to see if they could set that up as a variable that we could include in their demographics. Are they on public, at least public or private data? But at present, there is no way to control for insurance. And I hate that we live in a time where insurance status so directly predicts the kind of care that you get, but that is a limitation that we're facing with TriNetX at present. Hopefully that will change in the future, but I just want to make you aware of that. Another common question, especially from hospitalists, length of stay. How long were patients in the hospital following X surgery? The data can be derived from the downloaded data sets, but there is presently no way to assess length of stay from TriNetX. We can assess length of readmission. So from when they were admitted once, within 30 days, have then been readmitted to the emergency department for some other similar thing. We can look at that, but we can't look at how long they were actually in the hospital for with any degree of certainty. We have some sensitive data types, as I mentioned earlier, neonatal questions. You can still do some analysis. We were able to see some data related to that. One example was hypoxic ischemic encephalopathy. What are the rates of occurrence for those patients, for neonates with, and then how many of those received hypothermia as a treatment? That was a very specific question from one of our department chairs. We were able to actually calculate that, but we weren't able to do any additional analysis. We could see how many people fit that bill, but we couldn't do an on-platform comparison. So I just want to make you aware that the P series of neonatal questions are very restricted. Accidents, incidents, or violence, gun violence of certain types, deaths in war, car accidents, weightlessness, other things that might be possible to find in newspapers, those also can be restricted. My favorite, as I noted here, is weightless injuries related to weightlessness, conditions of weightlessness. And I often ask students, why do you think that that might be restricted? And they sometimes get it right. That's astronauts. There's only a few hundred astronauts in the world. So if you could find people who had incidents related to weightlessness, you would know probably within a degree of certainty that some of these folks were those astronauts. Questions related to ambiguous or qualitative outcomes or information not collected by EHRs. Do patients in cohort A report less pain than cohort B? There are some pain measures in TriNetX. However, those can be, there's actually a great New Yorker article this week on just the difficulty in assessing pain because it's such a subjective measure that there are 72 words on one of the assessment items for identifying pain. So that can be very challenging. Other questions that can be different are related to things like costs, comparative costs of treatment, A and B. You can figure this out other ways, but it's not really easy to see which is going to be the better case for this. We'll actually show an example next time of an example where we looked at where cost did factor in, but not in the way you'd think. So finally, though, great use cases. I like to end on a positive note for this kind of thing. Great use cases are things like disparities in treatment, risk likelihood, long-term outcomes for patients. That is, randomized controlled trials are fantastic. They're the gold standard in assessing causality. However, they are limited by cost. It can be very expensive to run long-term randomized controlled trials. We can do certain things by looking at people's natural health records that you couldn't do necessarily with that, which can answer certain questions that are unaddressed. If you look at meta-analyses of randomized controlled trials, often long-term conditions are very difficult to assess with any certainty. Finally, experimental conditions that might be otherwise unethical or impossible to replicate in the real world. I think we have an example tonight where that's going to be interesting to contemplate the ethical implications of that. So in summary, why TriNetX? Why is this important and relevant? Well, for medical students, this is an opportunity to develop your scientific knowledge and your medical sciences knowledge. I even met with a group today where I asked them, I'm like, why do you anticipate there would be a relationship in these two things you want to try to find correlations between? And I got a little bit of a blank stare for a moment, which is completely understandable. But what I think is great about this is it's an opportunity for them, for attendings out there who might be watching today or in the future, for them to come bug you and ask you for your medical knowledge. Why would these two events why would vitamin D and type 1 or type 2 diabetes, how do those things interact? Vitamin D deficiencies in type 1, type 2 diabetes. That was a project that a student tried really, really early on. However, she had to learn a lot about the differences between an autoimmune, disease and an endocrine disease, right? And how vitamin D interacts with those two different kinds of diseases. Because even though they're both technically diabetes, they have very different, and I'm no expert in this, but they are very different in terms of the unfolding of those diseases and how different hormones and things like vitamin D play into that. So in order just to make use of this, our students have to do a lot of research. And that's something that I've really seen them grow. When they glom onto this, they really run with it and learn so much about medicine, clinical medicine, from both their mentors and their own independent learning. But that's where self-directed learning, and that's what residency and program directors want to see, practicing that master adaptive learning, figuring out what you do and don't know, asking around, being self-motivated. That's something that I think program directors and our attendings really want to see you guys do. And I think this is a vehicle, a technology that allows us to do that. All right. Now on to the more kind of brass tacks of how do we actually get a project off the ground. Step one, students who have had me before, my second years, you guys know the first place you got to go for a project is your literature review. You cannot skip that part. I routinely meet with students and I'm like, well, what does the research say about this already? And they're like, well, I just read like a study and it said, I'm like, no, you got to really dig in here and find what are the gaps. Where are we finding, where are there methodological constraints in the study of this thing you're interested in? Where are the historical constraints? Where are people not looking? What's going on with this body of research? And to do that, you have to develop your expertise. And that's why the literature review is so central to the beginning of your process. Defining your question arises naturally from that, right? Then building your cohorts, that stuff is easy, right? All the buttons to click, all that stuff flows naturally from the definition of your question and reviewing literature. And then all the rest of the stuff we're going to talk about through the rest of this bootcamp, generating your initial outcomes, comparing your cohorts, propensity score matching, generating your initial outcomes, going back and revising your cohorts, which is a great learning opportunity, getting feedback and self-critique, and writing up your results. All of that flows, that starts with answering a question in the research that is unanswered. What don't we already know? How are we going to learn about this? We're going to talk about two things. My clunky metaphor for this is that we have foundations and the house. So the foundations in week 1, project and team management, available networks and query builder. These are the buttons. We're going to learn about what buttons to click to get these things started today. In our last 45 minutes or so of our discussion time today. And then weeks 2, we're going to talk about term groups and exploring the cohort, because that's really foundational. And then in week 3, we're going to move on to choosing an analysis tool. Week 4 is outcomes and stats, and week 5, proportional hazards model and time on treatment. Finally, leading into our last session on development. So knowing when to introduce features of TriNetX is going to really make your process better. Like I said, it's a clunky metaphor, but what are you going to do? Your foundation that supports the validity of your findings, the claims you're making. Extraordinary claims require extraordinary evidence. To do that, to make sure that you're submitting something of high quality that will endure forever and people will be citing forever, you have to make sure your inclusion and exclusion criteria are solid, that your time and order and frequency of events is well understood and well articulated in TriNetX, and that your cohort explanation for confounders is really well done. Then you can build your house safely on top of that, with cause-effect order being built in, your analysis type being selected wisely, your propensity score matching being done well, and finally your outcomes, your roof, building there. Terrible 4-year-old drawing in PowerPoint here like this. You can see that is how we get to a good quality study. The main goal of approaching TriNetX this way is to ensure that you're making the most of the platform's feature, relating cause, effect, and time, avoiding common evidentiary mistakes that result in bad data. I see this all the time. And unfortunately, sometimes people even submit these to conferences before coming to see me. And I'm like, no, wait, what's going on here, right? We have to talk about this, really think through the evidentiary dimensions of your project. Giving you a roadmap, this gives you a roadmap to follow for your future projects as well. All right. It's hard to demonstrate the platform's capability without a use case, so we're going to look at that a little bit really quickly. A good worked example is going to help illustrate how to apply the different features. Also, a good way to get at tacit knowledge and discuss ways of thinking about things. I'll be using this project that I'm going to show today to illustrate the various features of the platform, and also how sometimes things in the real world give us great ideas for projects, I think. Social media, as you all know, is full of questionable medical advice. And Instagram in particular is full of clownery, like this guy. I used to watch this thing because he had a lot of really good ideas about maternal nutrition. But this guy's claim, basically in this video, is that Alzheimer's is caused by physicians, by the overprescription of statins, by physicians pushing these drugs. I am not that kind of doctor, but he claims things like Alzheimer's is a physician-created disease. It didn't exist even 40 years ago, not even under another name. He's German and he always talks like this, and he stands in front of the video in his white t-shirt. But he is incorrect. All of that is factually wrong. And it's been around since 1906. The first statin wasn't even produced until 1987, right? But there were decades in which Alzheimer's was clearly identified. And even before it was named in 1906, it was identified as far back as the 1880s, and dementia has been understood for generations beyond that. This makes no sense. However, it got me thinking. There was actually, just about this time, a series of studies came out indicating that perhaps we are overprescribing statins. It may be that the people who need them are getting them at lower rates than the people who are actually getting them. And we may be, number one, wasting money, but also potentially exposing people to, over the long term, potentially negative side effects. However, it was more like an issue of rebalancing the risk profile for this drug than physicians pushing drugs or something like that. That's not really what's happening here. But Alzheimer's especially is very complicated. Cholesterol and statins and Alzheimer's. There's a lot of current controversies. Statin dosage increases over time. Length of treatment can be very, very long. We have comorbidities like vascular diseases and stroke that have nothing to do with or not nothing to do, but a different set of outcome or etiologies than Alzheimer's. There are dietary considerations. In every country where beef consumption is increasing, you see increased rates of Alzheimer's disease. We have poor understandings of Alzheimer's causes, right? Is it type 3 diabetes? Is it prions? Is it inflammation? Is it glial cells? Is it sleep? Who knows, right? We don't really have a good risk model for people, even though I saw a good article today indicating that maybe they can predict it as far back as people's teenage years, which is very sad and interesting. There's also genetic dimension. ApoE3 and 4, right? People have 3 or 4 copies of this gene. They have increased rates regardless of what drugs they're prescribed. And there's also an ethical dimension, right? If statins help with triglycerides, which can help to prevent long-term arterial claudication and all sorts of issues like that in heart health and cardiovascular health, is it ethical to withhold them to protect against the possibility of Alzheimer's in the distant future? That's something that is very difficult to test empirically, but it is something that is, for bioethicists out here, potentially very interesting. In another case, there are at least 2 meta-analyses, one of observational studies and one of randomized controlled trials that came up with not as clear-cut results as you would think based on some of these. So dementia risk reduction was on the order of 20% in one study, and Alzheimer's generally was on the order of 32% in another study. But that is, once again, from a meta-analysis of observational studies. And in the meta-analysis of randomized controlled trials, it's a lot murkier still. But there are no studies on Trinetics on Alzheimer's and statins yet. And it's a perfect analytical tool in some ways because it's hard to get longitudinal data on Alzheimer's patients. People drop out, they move, all sorts of things occur. They stop showing up to it. Their family members can't drop them off at your study site. They don't pick up the phone. It's hard to randomly assign people to a statin and no statin group because if they need the medication, they're going to have to be given it. And you can't. But however, people do frequently decline statins. It's actually, there's a code for it. Cohort matching can be challenging due to multiple comorbidities. So you can wind up having confusing assignments that can be very challenging to manage. And once you've assigned somebody, that's it. You can't unassign them or change them. You have to recruit somebody new to replace them. It also allows us to ask some specific questions. So the very simple questions I wanted to know are, if a statin is not associated with any changes in likelihood of development of Alzheimer's disease, that's our null hypothesis. And hypothesis 1, statin use is associated with a lower likelihood of developing Alzheimer's disease. So we're going to check that out. What we're going to talk about as we go in this TriNetX Bootcamp is I defined my cohorts. This is a cohort diagram. It's kind of like a Prisma diagram for TriNetX studies. I have versions of this that you can have to map your own study. You can see we have extensive exclusion criteria, and we're going to look at that in a moment in the actual platform. And we've set this up in a way that we think will ideally help to limit some of these confounders that we're seeing in other places. We propensity score matched our cohorts because if you don't propensity score match, curiously, it appears that statins shoot up the odds of Alzheimer's by 2 or 3 times. However, if you propensity score match, you just find out that one cohort, the statins cohort, is actually just 13 years older on average than the no statins cohort. So by controlling for age, by making sure we don't have a systematic difference between our 2 cohorts by age, that enables us to do a lot more work. And we're going to talk a lot about propensity score matching later, but more technically, it's a quasi-experimental method that uses statistical techniques to construct an artificial subgroup out of your main group that is used for matching so that when we are looking at them, they are apples to apples. And we'll explain that's just a very, very simplified version of it. We'll talk about it more later. But TriNetX will generate these outcomes. And what we found is that non-statin patients are about 2.23 times more likely to to be diagnosed with Alzheimer's later than the other group. Now, it's a very small group of people. It's a needle in a haystack, but that's because otherwise these folks are healthy. Otherwise, they don't have major risk factors for Alzheimer's. So we developed this into a poster. I'm working with some students now to develop this into a manuscript. Some folks might say, but 0.23% difference is clinically meaningless. Yeah, but the population level, this can be huge. Also, if you run this as an effect size, 2.23 times greater is an effect size of like 0.6, which is actually quite substantial even for a retrospective observational study of this scale. And the other thing to think about is if that number is even vaguely true, if you had 0.0023 times the 13 million patients in the study, that means a lower risk of Alzheimer's for 29,900 people. Lifetime costs of that would be a savings if we gave people otherwise almost free drug. I don't know if any of you are on statins, but most healthcare plans give it to you for $0. Your total medical and annual Medicare cost savings would be on the order of $11.96 billion per year, because Medicare costs overall by about 4%. So most medical plans, as I said, cover 100% of generic statins, so it's really no cost, low cost. And as I said, the Cohen's d of that is about 0.51, which is a medium to large effect. Otherwise, very healthy people with no comorbidities for Alzheimer's, not exactly the natural group out there, but worth looking at. So today, we're going to just look at the cohort. I know I've been leading up to the actual platform today, but let's talk about starting a study. We are now moving out of the station and into TriNetX. When you access TriNetX, you are going to see a screen that looks like this. You're going to enter your @medschool.ucr net ID, just like you see mine on the screen like this. I'm just going to pause my screen share while I do my Duo sign in so that we move through. Hold on 1 sec. You got to sign in pretty frequently. Okay. You'll enter your @ucr.edu net ID, and I know which is confusing, and your net ID and password, and then you'll get a thing that looks like this. It'll give you a nice green check mark in your Duo, and you'll move into our password or into our protected environment. All right. So when TriNetX loads, you'll see an option like this. You'll see a Create New Study button over here. And when you click on that, it'll enable you to fill out some really normal key things in here that you can use to start up your project. There are a couple of required fields. That includes your study name, your research purpose. You can see the study name boxes here. You do have to select a research purpose. You can just select some of these other scientific research areas over here. You also have to include your primary therapeutic area. You can put it in your area of specialty. I usually just select public health, though, because for our purposes, it really doesn't make a difference because this is not going to be used as a clinical trial proposal. Then you can also choose to share study with other team members. So when you check that box, it will enable you to add other folks to the project. I really recommend, if you are a student and you're working on this, add your colleagues and friends, add your mentors, add everybody to this to make sure that you can all see each other's work. It's very, very share friendly. So whenever anybody hits this blue button, count patients, it automatically locks in changes that everybody else can see. So these are the main areas you have to fill out to create a new study. Sometimes this gets a little confusing for folks, so we make that simple. Here you can see a screenshot of that, again, to highlight some of those areas if you want to refer back to this. Part 2, starting a study. Key startup features. A couple of things that I want to highlight. First, your available networks. You can see over here, when you click on this little menu, when you come to your study for the first time, I have a couple of extra ones in here, but you're going to see a couple here. You're going to see your US Collaborative Network, which has roughly 130 million patients in it. You're going to see the UC Collaborative Network with about 3.14 million patients in it. 2 of the 3 networks, UCR and UCI, are currently online, and the old data is no longer online. And you can also see here that there are about 180 million patients in the global network as well. So as we talked about earlier, these are nested Somebody has indicated that the TriNetX page isn't in view. Let me know if you still can't see it. My screen is saying that it's visible. Oh, okay, great. Cool. So your query builder is this function right here in your study. You can see it. When you click on this button, all of, as I said earlier, your ICD-10 codes become visible. You want to find everybody with cholera? Boom, there's your cholera patients right there globally. This is every person in the world who's walked into one of these healthcare networks and been seen to have cholera. Again, you've got differences in your networks that can be valuable to consider. And a couple of things I want to call to attention in the study search area are your terms search box here. So again, if we want to look for people with typhus, right? You got your typhoid right here. You can see people who have that. You can select options from here. For example, if you just want to see diagnosis of typhoid fever, you can click on that. You can see it's fairly rare, even globally, which is good. So once you add terms here, you might want to also move some of these around to create logic chains. This is actually a really great and important component of your study. You can move things in so that you can have your must-have box over here. These are features or codes that members of your cohort must have. And over here, you can see that these are features that they cannot have. So this group of people must have cholera, but cannot have typhoid. And you can really quickly move these around to trade that out and show that these are people with typhoid, but not cholera. So you can flip this around really easily. You can also really quickly create Boolean logic chains by using these little buttons down here. What this does is when you have two terms like this, you can click on it and say, I want to see everybody with typhoid and cholera. And you can also say, I want to see people with typhoid or cholera. And you can imagine that when you have people who have typhoid and cholera, you have, imagine a Venn diagram. That's a circle, a union circle. That is all 100% of people are in both groups. In this case, we have an intersection of people who have typhoid or cholera. And we're looking at the intersection of those two groups. We can let me just introduce you really quickly, though, to some of the other features in here that you might use. Looking at your demographics, if you're interested in ethnicity by which the US government and this platform means Hispanic and Latino or not, you can find that under the ethnicity box. If you're interested in language, you can sort people and add people by language. For example, people who speak only Spanish. Or this is essentially the box that would trigger the need for a translator and tell people what the translation is for. So you can see all the different languages that are shown across TriNetX, and you can look for people that way if you want to be more specific. You can also see marital status for folks, whether they're divorced, domestic partner, married, never married, those kinds of data that are collected. And you can also look at it by race. So you have American Indian, Asian, Black, or African American, Native Hawaiian, or white. I do not recommend using the other race or unknown race because they're not really meaningful. It just means that that health system was not collecting that information for those individuals. Similarly, you can also use this to identify individuals who are dead, who have died in their hospital system, and have that added to their record. I have a comment in the chat. Somebody asks that they are having trouble and it keeps going back to the login page. If you do, please send me an email about that, and I'll check to see if your account is configured, and we might have to do some troubleshooting around that as well. In addition, so as I said earlier, here are your diagnoses. We also have oncology data. This is data drawn directly from the National Cancer Registry and is aggregated across both the ICD-10 data and the cancer registry data. This includes expanded data about tumor histology and behavior, stages and biomarkers and things like that that are very precise. We had some students last year use the KRAS. They looked at some of these real rare KRAS variants, gene variants, to do some really great work. You can also look at things by procedures. CPT codes are organized generally around anesthesia, surgery, medical examinations, pathology, and laboratory procedures. So you can, search for a specific procedure, or you can, look down the group like that. You can also use the ICD-10 structure, which is a little bit different, to look for procedures. So difference to keep in mind is that CPT codes are privately curated by the American Medical Association and are licensed for use by health systems. However, the ICD-10 codes are free and so are much more broadly used globally and across the US for systems that don't want to use the CPT code for one reason or another. So those are just some things to keep in mind when you're looking for features. They fundamentally cover a lot of the same things. They have a lot of overlap. However, you might wind up running a study and only looking for procedures using CPT codes, but missing the ICD-10 codes that might also capture some of the patients that you're looking for. In addition to procedures, you have medications, all the different medications that are available in TriNetX. They all have medication codes that you can use to look them up, or you can look for them individually, penicillins and things like that. They're structured in the VA's hierarchy. You can also use, there's a structure called ATC that also helps you to identify them. But more frequently, it's just easier to search for things like Lexapro or something like that. It'll take you straight to that class of antidepressants and things like that. As I was saying earlier, there's a range of different kinds of LOINC codes that are brought in here for laboratory values. So you can see, if you're looking for A1C or anything like that, you can search for it, but you can also look for it in this hierarchy. We also, as I mentioned earlier, have access to the genetics. It's only about 26,000 patients genetic information here, but if you're doing something on BRCA 1 and 2, you can use this to identify a few hundred patients who have specifically been identified with those cancer variants. And as I said earlier as well, here are your ambulatory, emergency, home health, all sorts of different types of encounters that you could include as part of your study if that was something you were looking for. So that's your overall kind of term finder, if you want. But again, as I said earlier, if you're looking for A1C, you can just type it in, and you'll find sometimes that they have this option called TriNetX Curated. What that does is synthesize across a range of different individual tests. You can actually see these are all the different LOINC tests that are aggregated into one value. But this is the A1C for, in this case, the most recent lab value for anybody that you're looking for. So you can obviously say you are looking for people with an A1C greater than 6. And so you're going to start looking at what's going on with those folks, or you want to see what's going on with people above 7.5. You can do that, or people with very, very high blood sugar, right? Up in 10, 12, whatever. And you can look and see whether those people have different outcomes or anything like that very easily. So you can add that into your study. I don't know why we would find people with typhoid, cholera, and A1C, but you could. If we were looking for those folks, we could hit this. I'm actually going to take this out and just look for a broader group of folks in our 22 million patients with people of an A1C above 10. When you hit this count patients button, this blue button up at the top, that kind of locks in your query and pulls those people into your study. So right now it's searching across the whole world, across the 165 million people for those folks. And what we're going to see is over here, it creates this little card over here. This is a query card. And this query card allows you to then analyze these later on as you're going. What you'll find is that these queries, for example, we wanted to create an A1C less than 10. We could easily click that, hit the recount button, and it'll create an additional cohort of people who fit those parameters. So that can be a really, this is the basic way that you set up your cohorts in TriNetX. And as that's finishing up, I'll go show that to you. So one additional thing that I need to show you guys is, as soon as this is complete, You're going to want to, I'm going to guess, sort people by age or sex, because those are the two most predictive factors out there. So I'm going to show you how to do that in just a second. In fact, let me jump over here. Yeah, just to recap while that's finishing running, you can have your left columns are the must-have inclusion criteria. The right column is your cannot have exclusion criteria. You can drag them back and forth, and we'll get really granular about how to do this next week. You can use two things that I think are valuable here. I'll highlight again. You can use this filter function here to select more granular details about your group. But also, if you want to jump to where the A1C tests are located, you can hit this term hierarchy function to take you directly to that area under labs. This works the same for any kind of condition. If you're looking for people, again, with cholera or something like that, you could hit that and it will take you right back to where in the hierarchy those things are located. Let me just refresh my page real quick. Just a reminder that the TriNetX folks can't help you with resetting your password. Please do let me know if you're running into issues. That has to be done all on our side. Let me just reload the page. While this is reloading, do we have any questions? Anything that I can answer while we reload on this page? Just to show, as I was saying earlier, you got cholera. If you want to find out where is cholera in the disease hierarchy, you can press that button that looks like a series of dots, and it'll take you right back to that in the menu. We have a question in the chat. When sharing a study, do the others have to have a UCR email? Yes, they do, and they also have to have a TriNetX account. That's just part of, there's no way around it. Everybody needs a UCR email account in order to access the platform. Great. We have a question. Patients included on the medication tab, just people who are prescribed the medication. Yes, in the same way that medication adherence is really hard to see, it can be very difficult to, we can't really assess whether they were taking their medications, not any more than you could in any electronic health record. So that is a limitation. We can see how when they were prescribed and how many times it was prescribed. For example, how many years or how many individual times it was prescribed to them in their health record, but we can't tell if they were taking them actively or not. Somebody had a question a moment ago. Okay, just to revisit, we also talked about Boolean logic, using the and or functions to join terms or groups to make a big difference for finding the right people. That and or function can really can either over zoom on a group of people or exclude the wrong types of people. As I said a moment ago, that count patients button helps to identify people who locks in your cohort and helps to identify those folks in your cohorts over here. You can see that they start to get additional. Every time you hit the count patients button, you get an additional little card with your group, and you can always revisit them like this. And you can see they start to stack up over time. That every time you hit the count patients button, it's really important to name them carefully and to delete outdated ones. Otherwise, you can wind up with dozens of cohorts that are obsolete and just clog up your view. It's possible to search them by name. So naming them is really important. And making sure that you kind of version control them as you go is also really important. We have a question about under medications, are doses and frequency of prescription included? Dosage, yes. Let me just find one here. So if on if you're looking at medication, if you click on it, you can see whether it's a brand name, whether it's an oral or a IV route or whatever you're looking for. It'll display one of those. This is only an IV, and obviously an oral drug. And you can also see the different dosages that are available. Unfortunately, this view doesn't tell you how frequently it was prescribed, but it is possible to tell how many times a person has been given it in their record again. So you can see, I only want to see people who've been prescribed it for at least a year and at least had 5 prescriptions filled. I have a comment in here. Occasionally, I've not updated the diagnosis codes on patient charts because it's extra steps and adds to the workload. However, my notes will reflect more specifically the diagnosis. Does TriNetX look at notes for diagnosis too? No. It's structured data. They used to have a natural language processing tool, but it was found to be too unreliable because when people put that information in their notes, it doesn't show up properly, basically, and it doesn't show up consistently either. So it is a problem with data in terms of how recently something was diagnosed in relationship to something else. But it is a reason also to make sure that we are using, this is more of a health system decision, how frequently providers should be using their structured data to note that. Oh, okay, great. So somebody else, Dr. Friedman notes, hospitals have CDI programs that typically try to add missing codes to DC summaries. So that makes sense. Great. So in the great chain of things, I think they find, we also have a question. Can you do studies looking at the frequency of adverse effects from medications? Yes, that is a very common way TriNetX is used. They're actually used, the FDA is using it in a lot of cases for pharmacovigilance to make sure that the following release, some of these new drugs aren't causing unexpected side effects. I see, got somebody's unmuted. Would you like to make a comment? Okay. So I'll continue fielding questions as we go, and as we move on towards it, I want to make sure that we try to end on time with the formal phase of our night and move on to some of the kind of mentor and mentee matching that I hope we can accomplish as well before we close out. But some notes. We have some conceptual notes on cohorts and outcomes. Your cohort should never include the outcome that you're going to use to conduct your analysis. If your cohorts include people with Alzheimer's already, 100% of your population in your analysis is going to have Alzheimer's at the end. So you really don't want to include that here. If you're looking at people and you want to know whether people are more susceptible to cholera, including cholera in your cohort is going to drive that at the end. And you're going to wind up with that 100% of the time. It's not going to make any sense. So just making sure, and we'll talk more about cohorts and their relationship to outcomes in our next version. I want to introduce you to something. One of our first years came up with this when we first released it. This is the acronym that I often use for, it's a mnemonic. Doctors don't pay money late. And the idea here is that when you're looking at stuff in TriNetX, you want to make sure that you're going through your demographics, diagnoses, procedures, medications, labs, and genomics and visits pretty thoroughly each time to make sure you're not missing anything. As I said earlier, we looked a little bit at age, sex, race, ethnicity, which means really Latino or not Latino, marital status and vital status. And let me actually update this. If you're looking at age and sex, as I mentioned a moment ago, you can click this button up here where it says filters, and you'll be able to select by age and sex. So if you want to include people over 18, you can do that like this. You want to include only males, you can do that as well. And set this up, and when you hit your count patients button, it will again go through that process. So it's very straightforward to change out age and sex. It's just not included in the same menu as the other demographics. And you can also, one additional feature, I'll come back to that in a sec when it stops its count, but you can also set at the individual event level. Like, let's say you want to see people who are only only contracted cholera when they were 18 years old and no older or no younger, you can set that as well. Or people who contracted it between the ages of 18 and 22. That's very easy to set in the filter function as well, which this is done, I'll show you. Again, we looked at your diagnostic codes. Specific codes are sometimes collapsed into one code. This is something that's worth being aware of. This is just part of the problem maybe with ICD-10 is it is very complete, but it also has a range of kind of unaddressed or rather collapses sometimes very unusual skin conditions into other skin conditions as opposed to enumerating them individually. Or in this case, other and unspecified asthma can include a lot of different kinds of things you might be interested in. And when you search for it, it might show up, for example, if I can find this, atopic asthma gets collapsed in as part of mild intermittent asthma, which may not be exactly what you mean, but could be included in there. You can see sometimes they'll include that terminology right underneath the code that it believes is the most accurate. So that's just something to be aware of. As I said, there are some restricted and sensitive ICD-10 codes. My favorite, as I said earlier, was prolonged stay in weightlessness. Your CPT codes, I would suggest consulting Google or medical consulting guide, as I said earlier, to do that. Again, as was asked a few minutes ago, I think I already showed you this. If you click on the filter function, that'll show you all of the information available about drugs. So if you're looking for semaglutide, which is a very, very common medication to be studying these days, you can look at oral and injectable products. I'm not really sure why you'd look at oral, but you could. And you can see some of the different brand names of semaglutide, and you can see some of the other ones as well. If you're looking for some of the, you can search for the brand names of some of the semaglutide, SGLT2 combos, GLP-1, combos going on there. As I said earlier, your lab values, depending on the lab type, can provide additional details, and your TriNetX curated bundles multiple tests into one view. And when we proceed next week in technical training, I'm going to talk more about cohort design and how to explore your cohort and really understand who's in there. So that's the kind of technical component for tonight, just to get you started in terms of being able to navigate the interface, start up a project, start adding things to it, play with that a little bit. If you want to look ahead to next year's video, if you want to kind of jump a bit ahead, you can take a look at what we did. But that's the bulk of the technical training for tonight. So I just want to, for students, for folks who are watching, an additional kind of review of the overall project development process again. As I said earlier, all good projects start with a literature review. A lot of times I say people are like, thanks for the software demo. I'm just going to get in there and start playing with it. I've seen that really is a road to nowhere for a lot of projects. Having a really concrete question that you're trying to answer really is going to help you out. I'll come up with a good idea as I use it. Another way to kind of hit a dead end because you don't know if you're going to even find anything of use in the study. Great Trinetics studies don't start with software. They start in the library. This is the Suzolo library at UW where I wrote some of my dissertation. I wish all libraries looked like this, but this is a particularly nice one. Great Trinetics studies start in the library because, if you, research is I do a lot of cooking. My wife and I love to cook. So a lot of my analogies come from that. But, you might, depending on where you're working, your kitchen, your research environment might look a little more like the slide on the left, a little more rustic. You can do a lot of really amazing stuff with limited stuff, but like us out at UCR School of Medicine, our clinical research opportunities are a little more rustic like this. But maybe if you're over at City of Hope, where you have sometimes much more funding to equip your labs, and you have a much more comprehensive cancer center space, you might have something a little more futuristic, like the one on the right. One thing that, extending our kitchen metaphor here, TriNetX is like an instant pot for research. And what I mean by that is, does anybody have an instant pot at home? Maybe you've seen one or used it. It's basically like a fancy pressure cooker, but the internet loves it because everybody's instant pot is exactly the same. If you've got one, if I've got one, they're exactly alike. 5 minutes in my instant pot is exactly the same as 5 minutes in your instant pot, regardless of the elevation of our kitchen, regardless of how, if you're in a dorm room using it, it's the same as if you're in a kitchen using it. And that's one reason the internet loves it, is it's very standardized. But as I said, every dish needs a recipe, or if extending our cooking metaphor one step further, every dish needs a recipe. You might look at this and say, I'm just going to make whatever that is. I'm going to chop some stuff up and throw it into a bowl. But without the recipe, you really don't know what you're doing. And what's the leafy green stuff on top? What are the green chunks? Is that avocado? Or is it some sort of maybe fruit? What is this, right? The recipe will tell you that. So instead of just kind of throwing stuff randomly into a bowl, we want to find a recipe. And existing TriNetX studies are really great recipes for a couple of reasons. First, they tell you what's already been done and what their methodology was. Their methods section ideally lays out exactly how the studies were structured, just like an Instant Pot recipe. Your TriNetX project will be exactly the same structure as the one that was used. You can use exactly their codes to develop it, and you can also vamp on it and change it and look for different diseases or different codes. It also will tell you what kinds of groups of codes were used or what was excluded from that analysis and when that occurred. It indicates whether and how propensity score matching was used in the study. As I said a little earlier, you can find TriNetX recipes through TriNetX's website, where they have a comprehensive group of studies that have used TriNetX. You can use Google Scholar to find them, and also ChatGPT and Perplexity to identify existing studies. More Perplexity than ChatGPT. So I really recommend starting with a recipe and using that to build forward. Again, here's a publication. TriNetX has the publication listings. You can just search TriNetX and your research interest, and it'll give you an existing, comprehensive list of existing studies that have been done on that area. And on the Scholarly Activities portal, as I said earlier, there's a curated list of projects that I thought were pretty good methodologically and pretty sound and well designed. But as I said, returning back to our earlier meta-analysis on Alzheimer's, because I did this exact process just as the same as I would advocate that our students and everybody else do it. Check your meta-analyses, systematic reviews, and scoping reviews for ideas for your study. These research summaries are going to tell you what's already known, what's not known. And in particular, over here, I got the idea for part of the study because in those retrospective, or in that analysis of existing randomized controlled trials, they could not control for Alzheimer's related fact. They found that in their meta-analysis, they could not control for factors like cholesterol, carrying ApoE4, gender, vascular diseases. So they couldn't create sub-analyses of this. But that creates an opportunity for us to use TriNetX to do exactly that process and to look at it much more carefully. Sorry, jump back forward. As you can see, we've come a long way today. We're almost at the finish line, so thank you for your attention. So I'm going to suggest an even more rapid process for everybody here to follow to really get to a good quality study earlier. Slimmed down version of our rapid development process is to select your area of interest. That's the hardest part and the thing that I often tell students I can't do for them. Identify a study in that similar area. It doesn't have to be exactly the same area, but something similar that you can use as a recipe to develop it. So let's say you don't like cherries, you can make a peach pie instead, right? Just by finding the right kind of recipe and then adapting it wisely. So read the study thoroughly to understand their recipe, pull out key features, ICD-10 codes, CPT codes, time frame relationships, cohort structures. They'll tell you a lot of this, almost all of this in a good quality article. Reconstruct that study in TriNetX and refocus the structure on your topic and cohort that you're interested in. Maybe they looked at pediatrics and you're interested in geriatrics. Well, you can start with what they've developed and build from that to look at your outcome if that's something that's never been examined before. Then after that, check with an expert. If you are an expert, check with a colleague. That's, I think, a really rapid way to do a good quality study that's already, based on something that's already been peer reviewed. We're not just mindlessly replicating studies here. We're trying to find something that we can use as a good quality starting point. Benefits this approach: your study will more likely be able to add valuable population health and clinical practices by filling a key gap. Studies less likely to produce a junk study that just adds additional noise and uncertainty to an already crowded scientific field. And your study is more likely to satisfy reviewers as to the comprehensiveness, accuracy, and methodological understanding of the project, because ideally you'll be building from a study that's already been vetted enough to make it through peer review, so that you're building from something good, once again, from a good recipe. I just like to show people, this is, I use a new example with students to talk about how literature reviews dovetail really nicely in here. I think we'll do that next week as well. But here's a worked example of a study, not that I think is particularly excellent, but it does have 5 features that I'd really, really like to see our students and our faculty make sure they include in a good quality study. For example, these are actually 7 items here that we look at. I'll take you through them really quickly just because we're kind of running low on time. First, a clear layout of your inclusion and exclusion criteria for cohorts. How exactly did you set that up, and what was your logic? That's really important to assure people that you knew what you were doing and that you really thought those through carefully. You can see in this study, those are the 7 major characteristics that are highlighted that they included, as well as the specific ICD-10 codes they used to do that. Again, here is a way that we use our cohort construction diagram. I have these to provide for you that you can use in your own study. They're on the Scholarly Activities page, and I'll be talking about them when we get to that phase in session 6. But your cohort construction diagram is really essential. As I said, here's a template on the Scholarly Activities portal. You make a copy to your Google Drive. Clear temporal relationships. That's something you really need to think about from the very beginning. The use of propensity score matching when appropriate. How did you propensity score match? What characteristics did you choose? Why did you choose those characteristics? That's all something that you should really, really explain in the study. And they do a very good job of not only describing what they did, but why they did it. They say in specific, to avoid reverse causality, the follow-up initiated 30 days after the test and continued until 12 months. So they even describe temporality in relationship to that, to how they were propensity score matching. You want to make sure you have clear identification of potential confounders and means of mitigation in your cohort construction. That's something you'd want to do in any study, but it's particularly important here. They also have a very clear, what we kind of jokingly call table 1, because it's table 1 in almost every project, but it's a score clearly identifying before and after matching characteristics for this. And for those who are already TriNetX users, I'm going to have a little present at the end of today that's going to make this so much easier for you. But I did create a Google Docs template that's on the Scholarly Activity website that you could use if that was something you wanted to. Also, I'm going to really suggest you have clear representations of your outcomes, not just a bunch of pie charts and stuff like that. Things like forest plot diagrams really help to put in perspective how much some of these things make a difference on your outcomes, and how, what your 95% confidence interval is, what your mean is. Those kinds of things can be really valuable. Also, they include really clear results tables that really tell you exactly what happened. I've got a couple of examples up on the website and a general one as well. So in summary, these are some of the 7 characteristics, kind of top level, not really necessarily deep about the methodological design, but really characteristics that are important for you to consider including in your final study. I also think that we've had some really particularly interesting student projects that have come out of this work as well. We had somebody look at hormone replacement therapy in women's health across a whole battery of outcomes that have really, really, really not been examined over time. This one actually has made its way into publication, looking at racial disparities in melanoma metastasis. We also have some really great projects. This actually, a student used this exact technique to develop looking at utilization of advanced care directives, which is something that's included as a procedural code in our study. We have psychiatric studies that have been done as well, looking at children who've had cancer and what their psychiatric outcomes are. profoundly understudied, I think. And one I'm particularly proud of from a student who worked with some folks at St. Bernardine's here, looking at racial disparities in prescriptions of omalizumab and dupilumab, where dupilumab is a newer generation drug. He just found somewhere in a study he was reading that they noticed that Black patients weren't being prescribed this new drug as frequently as white patients. And he built a whole study based on that, looking at, number one, is dupilumab better than omalizumab, which is what's reported in the research? The answer is yes. We were able to confirm that that is the case in TriNetX just as much as it is in the existing prospective analysis. Number two, that white patients and Black patients were being prescribed this drug at different rates versus omalizumab. And number three, that rates of acute respiratory failure were much higher in Black patients who were given omalizumab than those given dupilumab, which indicates that there's actually a potential real risk of a disparity emerging in this year. And this could be related to any, we don't know why, right? We can't make causal inferences here, but we do know that this is something that bears further research, and ideally people go and do a prospective study based on that. So I wanted to highlight some great ideas from students in the past. We've had even more award-winning projects in the last year. We've had residents win awards, and I think this is really has been a great advantage for some of our stuff. Next week, we're not going to have to do as much theory-based stuff, highlighting context for you guys. We're going to get more directly into defining and exploring cohorts, which is the next phase in our development in TriNetX. So I got a couple questions in the chat. I know this was a lot of talking today. Next time is going to be a little more useful in terms of content. I'm going to stop the recording, and we've got time to answer questions, show you specific things, and do a little more sharing as well. So please feel free to unmute or place your question in the slide in the chat.